Hello, good afternoon, good evening, and good morning to everyone joining our today's Ask WHO session about COVID-19. Our focus are variants of concern of today's discussion, and in particular, we will provide you with update on Omicron sub-lineage BA.2, as we've seen high interest from our followers in the past days. If you're watching us on Twitter, as usual, use the hashtag AskWHO to send us your questions. And if you're watching us on other platforms, we will monitor our comments and I will pass the questions to our guests today. We have Dr. Maria Van Kerkhove, who you know well, again with us. Hello, Maria. Hi, we have a new guest, a WHO scientist who is working also on COVID-19 response, Lorenzo Subisi. Hello, Lorenzo.
Hi, Alex.
Thanks
for having me.
Thank you for joining us today. And would you please tell our viewers what is your job actually in WHO and in the response and how your day looks like, workday looks like?
Yeah, thanks indeed. So I am an expert in emerging viral diseases and specifically during my PhD I studied the first SARS coronavirus that emerged in China in 2002-2003. And now I no longer wear a lab coat. However, we work very closely with amazing scientists across the world that do. And basically what we do is we compile the evidence that comes from them and share back through guidances and statements and yeah.
And you are one of our main scientists who is tracking all these COVID-19 variants of concern, right?
Yes.
So we have the right guy today to tell us all about variants and answer your questions. But we also have a very special guest who is connected with us from India today. It's Dr. Anurag Agrawal, who is a biomedical scientist and who is also a chair of WHO Technical Advisory Group on COVID-19 virus evolution. Good evening to you, Dr. Anurag.
Hi, Alex. Pleasure to be here.
Thank you so much for joining us today as well, as the advisory group met yesterday to discuss this sub-lineage BA.2 that I mentioned at the beginning. But before we start taking questions, maybe you can also tell us about your expertise and work in India.
Thanks, Alex. So by training, I'm a respiratory physician. By current work, I head an Institute of Genomics and Integrative Biology in India, which has been heavily involved in sequencing SARS-CoV-2 and also running cohorts across India. So yes, within India, we try to coordinate molecular surveillance and look forward to working with other colleagues around the world to take us all forward and all of this.
Thank you so much for your time this evening. It's late for you. Maria, as usual, maybe we can start with epidemiological update. Last week we had that worrisome trend of increase in deaths. So is that still the case?
So thanks, Alex. And I also want to welcome Lorenzo and Anurag joining this live Q&A. It's really a privilege to have them. Lorenzo, he's modest, but he is a coronavirus expert, someone who really, really knows this virus. And I'm so pleased that he's joined my team a while back now, but he's fantastic. And Anurag is a pleasure to work with as the chair of our tag for virus evolution. So it's a real pleasure to have them and a real treat for our viewers. And I hope our goal today is really to kind of explain some of these really complex issues related to virus and virus evolution. So thanks to you for suggesting this and having this opportunity. So thanks for that. In terms of the epidemiology of COVID-19, we are obviously still tracking this virus very, very closely around the world. At a global level, the reports of cases has reduced this week compared to last week. In fact, we see about a 20% reduction with almost 13 million cases being reported to WHO at a global level. It varies by region. We've seen a decrease in all regions with the exception of the Western Pacific. Now, I want to put some caution around this because the amount of testing that is occurring in countries is reducing substantially. And I think one of the big messages that we have today is to encourage countries to still test for SARS-CoV-2. This is absolutely critical to the topic of today, which is around detecting variants and making sure we understand how this virus is evolving. And the start of that is good surveillance and good testing, because you can't sequence a virus that isn't actually detected in a patient. And that's really, really critical. So this declining trend that we're seeing in about a 20% reduction in cases may not be real. However, we are seeing a number of countries that have passed their peak of Omicron, where they are seeing declining trends. We'll get into the details of the BA.1 versus the BA.2, but Omicron is a variant of concern that is dominant worldwide. And we know this from sequencing around the world and the amount of sequencing that is shared on platforms like GISAID. So Omicron has replaced Delta at a global level in terms of what is being shared. Many countries have passed their peak, but not all countries have passed their peak. If we look at deaths, at a global level, almost 68,000 people were reported to have died last week, in the last week alone. That is a decrease from the week before, but again, I want to caution on this because we know some countries haven't reported their deaths yet to us. And in some countries, there's been a strange reporting, in terms of we have to verify some reductions in those and make sure that that reduction is actually real. The deaths are worrying for us. Even though we may see a slight decline, if that decline is in fact real, these are far too many deaths to be reported. And at this level, in the pandemic, in the third year of this pandemic, far too many people are dying. So for me, the death trends are very worrying still. We did see an increase of about 20% in reported deaths in Africa, about a 21% increase in the Western Pacific, and other regions are reporting declines. But again, we know that Omicron is globally dominant. Omicron is less severe than Delta, but it is not a mild virus. This is a dangerous virus, and there are still some countries that are seeing overwhelmed hospital systems. We're trying to track that on a more regular basis in countries and really look at burden. And so we're not out of the woods. So potentially some good news in terms of declines, but we have to look at these with caution because testing strategies have changed drastically in countries.
Maria, for this very thorough overview of what's happening around the world. And yesterday, the advisory group that Dr. Anurag is chairing has met to discuss this BA.2 lineage, sub-lineage of Omicron. So maybe, Lorenzo, you can tell us what are the outcomes of the meeting, and Dr. Anurag as well, what were your recommendations to WHO?
Yeah, so I think the group has looked at the latest evidence, and the group is made, let me clarify, the group is made of an amazing number of scientists across the world that work tireless to characterize these variants that are emerging, and so the nice thing of this group is that they share data very, very fast, and so we have looked at the latest evidence, and we have assessed the differences in the characteristics of BA.1 versus BA.2 in terms of transmissibility, severity, and immune escape, and other characteristics. And I'll let you, maybe Anurag, mention the conclusion of the meetings.
Sure, Lorenzo. So, the meeting start by pointing out that BA.2 is already a variant of concern. It is an Omicron. So the real question to us was whether BA.1 and BA.2 are sufficiently different clinically to be distinguished by new nomenclature. And for all practical purposes, we found that the similarity of fundamentally high transmissibility, lower severity, ability to aid vaccines was roughly similar based on currently available data. And we did take all data into account while concluding that for the time being, Omicron is a sufficient label for both BA.1 and BA.2.
Thank you. Please, Maria, go ahead.
So if I can also supplement that, I think what is important is that this group meets regularly. So it isn't necessarily a special meeting of this particular group specifically. They meet almost weekly. I think you're now going every other week now. And what this group does, their main task is to look at the virus and as it evolves over time. They're looking at specific mutations within the genome in the spike protein outside of the spike protein. And they're helping WHO to assess each of these variants that are detected through sequencing and through sharing of those sequences, to work with scientists around the world to look at the latest studies on transmission, on severity, on the impact of vaccines and the use of vaccines and neutralization, we call it in those studies. And every week they meet, now every other week they meet to discuss what is the latest. The meeting yesterday was specifically to get an update on Omicron And I would like to reiterate that Omicron is a variant of concern. And we are tracking Omicron in several sublineages. The most prominent ones that are detected worldwide are BA.1, BA.1.1, and BA.2. There's also BA.3, and there are other sublineages as well. And what this group was looking at is what's the latest. And I think a lot of people out there have heard of this Japanese study that came out as a preprint. And this is a study that is an experimental study looking at hamsters in particular. And what they were looking at is whether or not experimentally within the hamsters, if there was a signal of causing more severe disease under these experimental conditions. Now, these studies are critically important to be done. And this group, the TAG-VE, is working with scientists around the world who are doing these studies regularly on these variants. So this is the latest study, particularly looking at BA.2. And what is great about this is that we have the ability to compare the sublineages, BA.1 versus BA.2. Now, this preprint suggested that there was some increased severity in hamsters. But what this group evaluated yesterday was not only that study, which we actually had the researchers present to us, and we're very grateful for them for doing that, but we're also looking at severity in what we call the real world. We're looking at severity signals in people. And are we seeing any differences in severity at a population level in terms of increased risk of hospitalization of people who were infected with BA.2 compared to BA.1? And what this group evaluated from several countries is that we are not seeing a difference in severity of BA.1 compared to BA.2. So this is a similar level of severity as it relates to risk of hospitalization. And this is really important because in many countries, they've had a substantial amount of circulation of both BA.1 and BA.2. And in those countries, they have not seen a change in severity of BA.1 compared to BA.2. So in addition to the experimental study, we look at the real world data. And so what Anurag was describing is BA.2 sufficiently different? Certainly genomically, and the genome is different, and maybe you guys can explain this a little bit more, because if you look at the phylogenetic tree, there are genetic differences, but what we want to know is the virus behaving differently? Is BA.2 behaving differently than BA.1? It is more transmissible, yes, but in terms of severity, we aren't seeing that, and that's really critical. So for the person who's out there who's watching, these are a lot of numbers and a lot of letters, but what you need to know is the SARS-CoV-2 virus, whatever variant is circulating, is a virus that we need to maintain our vigilance, we need to look out for, and we need to protect ourselves. So for you who's watching out there, it doesn't matter if it's BA.1 or BA.2, SARS-CoV-2 and COVID is a serious disease, and we want to protect you. And we want to give you the information that you need to protect yourself and your loved ones. And you can do this: masking, distancing, making sure that you avoid crowds, getting vaccinated when it's your turn. And I think lastly, I'm sorry I'm going on really long, but I think it's important. Lastly, the vaccines work. Vaccines, the COVID-19 vaccines that are out there are incredibly protective against severe disease and death, including against Omicron, both BA.1 and BA.2. So when it is your turn, please get vaccinated. This is the single most important thing that you can do. And this is why WHO is spending so much time making sure that we have access, that people around the world have access to the vaccine, particularly those who are most vulnerable. So get vaccinated when it's your turn.
Thank you so much, Maria. You already answered some questions that we received. One of our viewers was asking about the new subvariants or sublineages, so you provided that update very well. But Lorenzo, maybe you can take this one from Denise Quarrington, who is asking if Delta can come back. Maria was saying Omicron is dominant and overtaken Delta, but is it possible for a variant to come back?
So I think that's a very important question, and I would like to mention first that in terms of the evolution of the virus, it is difficult at this stage to predict what will come next. So I think we can study the patterns of evolution over time, but we have not so much time as elapsed since the emergence. So we are seeing different patterns in terms of the evolutionary trajectory of the virus. So this is largely unpredictable as of today.
But when one variant overtakes another, can that previous variant come back and overtake, or that's not really the way the viruses in general work?
Well, the Omicron has overcome other variants because of its characteristics being more transmissible and being able to evade immunity, which has built up to high levels if you add up natural infection and vaccination. However, I think it's important to reiterate that we can't exclude any scenario at this stage. There are scenarios that are more likely than others, but none can be excluded.
Thank you so much. And you just said we don't know what's next, so we may have new variants. So maybe Dr. Anurag, you can tell us when the advisory group meets and there is a new variant that's emerging, what are the criteria that you take into account to declare a variant of concern? Or actually to advise WHO to declare a variant of concern? Apologies.
Thank you very much, Alex. That last line was very important. The VE group can only advise, and it's an independent group of experts. So, when you start with any new variant, what you're talking about is a new sequence that contains mutations that are sufficiently different from the ones circulating, and some of them are either known to or predicted to change the properties of the virus. So when you see something is of concern, you mean one of three things. You either are thinking that this change will lead to greater transmissibility, larger outbreaks. You could be looking at simultaneously whether it will cause increased virulence or severity. That is much harder to pick from a sequence alone. And the last part, whether it will lead to any problems with current diagnostics, current therapeutics, and cause a failure of strategies known to work in the past. If any of these criteria is met to a highly significant level, then we call it a variant of concern. And as an intermediate step, where you would imagine that these mutations look like they might be causing something, but there is not sufficient data to know that it is of concern yet, it will be a variant of interest that we would study further. And clearly sequence can tell you some things well, particularly, for example, now with sequence, we are very good at figuring out whether antibody binding will be reduced or not. But when it comes to fundamental issues of virulence, it is still very hard. So this is where the TAG-VE now meets not once, but regularly and continuously evaluates all kind of evidence, starting from sequence to, real immune escape studies, to clinical epidemiological data from around the world, and in due course, live animal studies and animal models. And all of this, when it comes together and points in the same direction, as it did for Omicron, our life is easy. Sometimes when it points in different directions, as we saw in the discussion for BA.2, it can be a little bit complicated, but by and large, we learn how to prioritize the best available evidence and give guidance and advice to the main bodies like WHO, and we review it on a frequent basis.
Thank you so much. And when the advisory group is reviewing all these data, do you think that there is enough data, or we would like to have it more?
Well, as a scientist, there is never enough and perfect data, but you make do with what you have. In terms of sequencing, I think the quality of data has got better and better with time. There are some fundamental limitations when you want to judge severity. And one of those limitations is that the population itself has far greater immunity today than it used to. So when you want to judge the severity of a virus going forward, distinguishing, the vaccinated and unvaccinated is not sufficient, because many people may be unvaccinated but are previously exposed. So it has become harder, and you expect the data coming out of animal studies, which are non-immune, to start diverging from human data. But you try the best using different combinations to make the judgment anyway.
So Alex, can I also supplement that? Because I think, as Anurag said, as scientists, there's never enough data, which is for sure. And you hear us calling for more data all the time here. So I fully support that. But two things I want to comment on. One is, for certain, we will have continued virus evolution. This is what viruses do. They change over time, and the more the virus circulates, the more opportunities it has to change. So we expect there to be future variants. This is why tracking and monitoring is so important. And it's not just the characteristics of the virus itself, it's the circulation. So we could have variants that emerge that may have properties that are quite concerning. But if it doesn't circulate, then it doesn't become a public health threat. And so we're tracking both the characteristics of the variants, and we have the help of the tag VE to do this with people from around the world, but also tracking the circulation is critical. So the second point I want to make is around the sequencing, the testing that's happening. Now, we are very concerned about a reduction in testing around the world. We need to continue to test for SARS-CoV-2. We cannot abandon our testing practices. We need to be smart about this. We need to be strategic about this, but we cannot abandon it. And what we do not want to see is the dismantling of these surveillance systems that have been put in place for COVID-19. This pandemic has been a horrible situation for everyone worldwide, but many countries have used the situation that they're in to build systems that are important for SARS-CoV-2, but will be important for any future public health threat that we have, the next disease X that's out there. And don't worry, we're not going to talk about that yet, but we need to have surveillance systems in place. And so we are very concerned about a reduction, or significant reduction, or an abandonment of testing, because number one, we need people to know if they're infected or not so they know what to do. Getting patients into the clinical care pathway is absolutely essential for whatever they have to make sure that they're cared for. We do want to continue to prevent the onward spread. We can't prevent all infections. We cannot prevent all onward spread, but we do need to do what we can to minimize it, because this intense level of circulation will only lead to more variants. And we also need to increase our sequencing around the world. And it's not just about more, but it's about having better geographic representation around the world so that we have sequencing coming from countries and in country being done at the local level so that these samples don't have to be shipped around the world, but can be done by scientists in country so that they have that power of information and they can use that information to guide their local responses. So we're very concerned about a significant reduction in testing or an abandonment of testing. Now is not the time to abandon the systems that have been built in place. It's the same thing for other interventions. Now is not the time to just drop everything. We need to be very careful about what is being done because we have to limit the spread as well as reduce severity and death. And we can do that through reduced severity and death through vaccination, through earlier clinical care. We also have to reduce the spread as much as feasible. And I'm not talking about locking people away or locking down countries, but doing the minimum. Wearing of a well-fitting mask over your nose and mouth, keeping some distance, working from home when you can, investing in ventilation where we live, where we work, where we study. All of these things continue to be important because we can't just let the virus continue to spread at the level that it's spreading, or else we will have these future variants. And we cannot predict exactly what will happen, with the exception of knowing that more variants will emerge.
So much, Maria. And Lorenzo, maybe you can take this question. It was one of the first questions we received today. Is it true that BA.2 is more difficult to detect with PCR test?
So thanks for this question. So I would like to, it is, there is some PCR assays that so BA.2 has doesn't have mutations that cause the S gene, we call it S gene target failure, which means that some certain PCR assays are unable, certain PCR assays can be used for surveillance purposes to see whether this variant is circulating or not circulating. And BA.2, as opposed to BA.1, does not have these mutations, and therefore the PCR tests cannot be used for surveillance purposes unless there is dominance of BA.1 and then there is BA.2 increasing over BA.1, and then you see this shift in the S gene target profile. So the diagnostics still continue to work for BA.2. There is absolutely no problem. However, the use for surveillance purposes for certain PCR assays is modified in the presence of BA.2.
Thank you so much.
Can I also comment on that too? Because we also have, you mentioned specifically on the PCR test, and as Lorenzo said, the PCR tests are working. There's one particular test that has a challenge with BA.2 because BA.2 doesn't have this particular mutation. But please be rest assured that the PCR tests are able to detect SARS-CoV-2 and in particular BA.2. We also have antigen-based tests that are being used around the world. And in fact, we would like to see more antigen tests be used because they're reliable. They provide results very rapidly. They could be used outside of clinical and labs. They could be used more in the communities and actually get closer to people so that they can make better informed decisions. And the antigen-based tests are performing very well against Omicron, indeed. So I think we want to reassure people out there that the tests continue to work, as well as the therapeutics, with the exception of some of the monoclonal antibodies, and the vaccines are working. So again, that's why it's so important that we keep tracking this so that we make sure that our countermeasures, we call these countermeasures, and our surveillance tools continue to work. So that's important. We have PCR tests and antigen-based tests that are being used worldwide.
Thank you, Maria. Thank you, Lorenzo. Dr. Anurag, do you have anything to complement?
No, I think Maria made the main point. People mean different things in their mind when they hear about PCR tests. Tests for SARS-CoV-2 continue to function well. PCR tests designed to give you a quick result before you have sequencing get more complicated with the various lineages within Omicron. But by and large, we are not failing to detect SARS-CoV-2 infections in people using current PCR tests. Just want to amplify that.
Thank you so much. We've been talking about different potential scenarios and that this virus is still evolving and emerging. So one of our LinkedIn viewers is asking if one of the scenarios is that Delta and Omicron may be merging and creating a new variant. I think, Maria, we've been addressing this before, but would be good to clarify maybe as well.
Go to the experts to come in on this. So, not only are we tracking sort of the evolution of the virus and the changes of the mutation, we're also looking at potential recombination events. And people have heard certain words of combining two words together, which I won't say today because we don't use those. And I think those words are quite scary in terms of looking at recombination. And what we mean is literally the combination of two viruses together. They have certain parts of the genome of one virus and certain parts of the genome of another. And that's something that we're looking at. Now, at a global level, the world is much better at looking for and detecting. So we may start to see some recombinants. Where we see pieces of different viruses come together. That may happen, but it could be a reflection of better surveillance. So I just want to put that out there because that may sound scary. But there are scientists around the world that are looking at the possibility. And one of the reasons I think, and it was discussed at the meeting yesterday, one of the reasons we are able to look for recombinants is because Omicron and the variant is so different than other variants of concern that have circulated previously in terms of its genome, the codes, that you look in on it. And so this may happen. We have seen some people who could be co-infected with two different SARS-CoV-2 viruses. Certainly that is possible, and we've seen that happen. We have not seen that reflect a change in severity, so I do want to make that point. Like if somebody is infected with two SARS-CoV-2 viruses, it's certainly possible. We aren't detecting that on a wide scale, so I don't want people to be alarmed by that. But we also haven't seen a change in severity. People have asked us if you can have flu and COVID together at the same time. Of course, that is also possible, but we haven't seen an increase in severity with something like that. So I don't want to scare people out there with the idea of recombinants, but maybe we can go to the real experts here and talk about what it actually means to have a recombinant virus and from a public health perspective and from a general public perspective.
I just want to say, Maria, I think you're the real expert as well.
Well, thanks,
so we have three real experts here, but yes, I'll give the floor to Lorenzo and Dr. Anurag as well to comment on this.
So yes, just to say that yes, so coronaviruses are known to recombine. So they recombine all the time. We see this a lot in bats. And so this is something that can happen. However, the fact that we are detecting it, as Maria said, is also because surveillance is getting better. And one important thing I'd like to mention is that, of course, the more the virus circulates, the more likely these events are to happen. And for example, there was at the time Omicron entered some countries, there was still very high circulation of Delta. So I think co-infection were more likely, and so of course the best thing to do is try to lower the transmission of the virus in general. Having said that, I think that we need to think about recombination like we think of mutations of the virus. So the virus mutates all the time, and I think many of the mutations, they are detrimental to the virus or they don't have an effect, and that's the same for the recombination. So we have to also think about that when we would think about recombination.
Thank you so much, Lorenzo. Dr. Anurag, anything from you to add to this question?
Yeah, sure. I mean, I think this is a very important topic, and viruses will recombine. So you will get certain recombinations. As Maria pointed out earlier, the best way of stopping all this from happening is to reduce transmission. The less the transmission, the less the chances of rare events occurring. But on a more technical point, when people speak of recombination and start fusing two words together, they're thinking of a progeny that is, like as bad as both bad elements of the parents together. First, that's not the way it necessarily occurs. Number two, the majority of sequences that contain elements of two different strains of the virus, two different lineages, often tend to come simply from co-infections or from contamination. That's the vast majority of the case. However, there are certain cases in which it is very clear it is the same virus in which two different parts have come together. That's called recombination. And then the next important thing to do is to see if it's capable of spreading and forming clusters. And that indeed is also being seen. But as long as the rate of forming new clusters is not more than previous, it is not in itself a matter of concern. And these are natural events. The better you study them, the more it will occur. And to just expand upon an analogy that Maria gave, if you were taking two photographs of twins and putting bits and pieces together, you couldn't really tell the difference, could you? So these things have been occurring in the past. What you have this time is you have two very different looking, in terms of sequence, viral lineages. So when you put bits and pieces together, it becomes very obvious. There is nothing more to it, I think, than that. Otherwise, recombinations have clearly been shown to occur in the past as well.
Thank you very much. We've also received questions from viewers on how long does it take for a virus to mutate from one variant to another. So I don't know if there is a specific answer, but what do we know from studies?
It's happening all the time. I mean, this is what viruses do. Every time it replicates, every time it passes from one person to another, there are small changes. So this is why it's been so important for us to track this since the beginning. I mean, Lorenzo will know I was quite obsessed with the idea of having a working group on virus evolution from the beginning of this pandemic, specifically because of this. There was one change in the beginning where it was the D614G. And this virus was different from the ancestral strain, the original virus that was detected from China. And that virus, the D614G, one change, was rapidly replaced. The original strain, I think it was early detected in late January 2020, and it replaced the ancestral strain by June, if I'm correct, if I'm remembering the data correctly. But this is why it's so important to track, because the more it exchanges between people, and the virus, as it replicates, it has this proofreading mechanism, but it's imperfect. And so there are expected changes. This is virus evolution, and it's natural. It's not an unnatural thing. It's what happens with viruses. But the rate at which it changes, it depends. I mean, there's a standard rate, and maybe you could mention that. But there are factors that can change this, right? There are factors that if you remember, I'm not sure if you remember the cluster 5 variant. This was one of the early variants that we detected in September 2020. And this was detected in Denmark, if I remember correctly. And it was from replication in mink. The virus went from humans to mink, and it transmitted amongst mink populations, and there were a lot of mutations that were detected, and then it transmitted back from mink to humans. That variant, that cluster 5 variant, didn't take off in human population, didn't spread easily. So we were lucky with that one. But there's that possibility. So all of us, the three of us here, all of us at WHO with our partners around the world are looking at different types of scenarios. You mentioned scenarios. So we expect the virus to evolve, but how it evolves, we don't have a crystal ball. It could become more transmissible. It could be more severe. It could be less severe. It could have more properties of immune escape or not. And all of us here and all of our partners around the world, all of the countries have to prepare for these scenarios because we don't know exactly what will happen. That's why we as an organization issue the guidance. That's why we as an organization try to work so rapidly to find these, to detect these, to assess them, so that we could provide advice as quickly as possible if something needs to change. So I don't know if I can emphasize that enough, but the ability to do that in a rapid way, almost in real time. I mean, most of the data that comes to the TAG BE, the Technical Advisory Group for Virus Evolution, comes to us before it's a preprint, before it ends up on Twitter, before it ends up in the public space. And that's the position that I think our member states want WHO to be in, so that we can actually assess it. And that we work with scientists like Anurag and our partners around the world to help us make sense of it all, because it's quite complicated.
Thank you, Maria. I would give the floor as well to Lorenzo and Dr. Anurag, so they can also comment.
Yes, I think that what Maria said is completely correct. I think that we see, on average, I think one nucleotide change every couple of weeks, but that first of all needs to translate into changes at the protein level, and then the change in the protein level needs to have an impact in the virus behavior. So it's really difficult to say when it's going to be the next variant of concern, because all this process is so unpredictable.
Thank you. Dr. Anurag?
I'm going to go out on a limb here and try to divide the logic of why it takes a bit longer now for new variants to emerge. In the beginning, when there is very little immunity. So you see, a virus to gain a foothold and displace previous versions needs to have greater overall infectivity. It can come in two ways. It can have more innate transmissibility, which basically means given enough uninfected people, from one person, the total number of new infections will be greater. Or it can have greater immune escape, in which case it can start infecting people who are otherwise protected. In the beginning of the pandemic, even single mutations that increase transmissibility, D614G that Maria mentioned is possibly one of the best examples, possibly the original VOC that never got a name. Those were sufficient to give a huge amount of advantage. As we are coming towards this part of the pandemic 2 years down, we are looking at a population with very large amount of immunity. We are looking at very optimized versions of the virus with high levels of transmissibility. So immune escape, which requires greater number of mutations to escape previous antibodies immediately, in short periods of time. So I think the number of mutations required to create sufficient immune escape the way Omicron did will take longer to emerge compared to earlier versions, when simple single 2 or 3 mutations giving greater transmissibility was sufficient. But coming back to the point Maria makes again and again, even a large number of mutations can occur over a short period of time in a low probability event if the number of infections are very large and opportunities are given to the virus. So while we are in a better place, I think going forward, the crux remains reducing the number of infections.
Thank you very much, Dr. Anurag. Here's the next question that I think is also important to highlight from the studies. Is BA.1.1.2 different enough so that people who had other Omicron variants are at risk?
This is a very good question. So this is another factor that the TAG BE and many scientists around the world are looking at. Can somebody who had BA.1, which was circulating, was dominant, and now we're seeing an increased proportion in BA.2, be infected again? And that is something that we're looking at. There's a couple ways that we're looking at. There are specific studies that are looking at reinfection risk. People that had a previous infection, can they be infected again? What's the risk of reinfection of BA.1 compared to BA.2? I can cut to the punchline right now, is that we are not seeing a change in reinfection risk of people with BA.2 compared to BA.1. The other, and that's coming from studies from some countries, and there's emerging evidence or increasing evidence from other countries that are supporting that. The other thing we're looking at, not looking specifically at sequencing, is if you look at the epi curves. So these are the data that we look at on a daily basis from all countries that look at, remember the sharp increase in Omicron in the incidence and cases, and then that decline. One of the things that we are tracking very closely is to see that in the decline, and many countries are in that state of decline. They're going down that, as Mike calls it, down the mountain at different paces, but are we starting to see an increase again? And particularly in countries that have an increased detection of BA.2, we're not seeing that. And that's really important because in this real world data, now take into account the surveillance issues that I mentioned earlier, that we are seeing reduced numbers of cases, but as we're seeing that decline in cases in countries, we're not seeing an increase again with BA.2. That's important. And that's something that we're monitoring extremely closely, because if we were to see an increase again, then this notion of reinfection would be more obvious. We're not seeing that, and I think that's a really good sign. But it's still early days. You know, I don't want to sound too concrete. We shouldn't sound too concrete in anything that we're saying, because we're still learning. Even though we're 3 years in, and even though we work with amazing people around the world to help us, we still don't know everything about this virus. But again, the increase and the decrease in incidence is not showing an uptick, again, particularly in countries that are detecting BA.2.
Thank you so much, Maria. Dr. Anurag, do you have any comments to this question as well, or Lorenzo?
I can maybe add one important bit to it, that these things are very dependent on time. So right now, we only have a short amount of data between the initial infections with BA.1 and exposures. There is not a significant uptick. There seems to be a very high degree of protection, at least at 1.5 months to 2 months out. How this will translate over time is something that only time can tell. But as of now, there seems to be significant protection between BA.1 to BA.2 and vice versa, which is one of the important determining factors for us in keeping them together under the same nomenclature, Omicron.
Thank you so much, Lorenzo. Any comments from you?
Well, I completely agree. I'd like to add that really the assessment of these variants is a multidisciplinary approach. So we have our group of experts is made of epidemiologists, clinicians, laboratory experts, as well as sequencing experts, modeling experts. So it is really complex to disentangle how these viruses behave, and only a multidisciplinary approach can be used for that.
You mentioned we also have clinicians on our team. So Maria, maybe you can take this question from Lynn Gellark, who is asking if we are looking at identifying new or further treatments for the new variants.
We're looking at treatments for all of the variants and in this virus. And what we have to plan for is the evolution of this virus. And we're looking at lots of different types of therapeutics. There are many therapeutics that WHO recommends already, focusing on people who have severe disease, people who are hospitalized, and there are many recommendations out for this. We're also looking at antivirals for people who are in the early phase, the early disease course. And that's really important so that we have a whole suite of therapeutics that can be available. So our clinical team, led by Dr. Janet Diaz, and I know you've done some live Q&As with her as well, and her team and the team of clinicians, again, a multidisciplinary group of even clinicians with pediatricians as well as pulmonologists and infectious disease specialists, et cetera, are looking at all those treatments. And I should also mention we're looking at also long COVID and post-COVID condition. So when we think of a patient, we think of a person, everyone that's out there, and we know a lot of people are suffering from post-COVID condition. What we're looking at is how people can know about their infection status, that they can get into that clinical care pathway, and that they can receive the right care that they need. Now, no matter when someone comes to healthcare, even if it's after they've had the disease or if they're suffering from post-COVID condition, we as WHO want to make sure that you receive the right care that you need, wherever you are in your disease course. So we're working very hard to make sure that we have good clinical care guidance that's out there through the whole spectrum, from the early disease phase. First of all, we want to prevent infections in the first place, and we do that with vaccination, which doesn't prevent all infections, but it's working very well against infections and transmission. But we want to get people into that clinical care pathway because early care saves lives. We are using oxygen as well, so don't forget that we have oxygen, we have mechanical ventilation, so there's a lot of tools that we have that work that save people's lives. But We are continuing to look at different types of therapeutics, from early disease all the way through severe disease to prevent people from dying, as well as providing care from post-COVID condition. But the teams are looking at each of these variants and if there's an impact on the therapeutics. So not just the diagnostics, not just the vaccines, but also the therapeutics. So it's a really dynamic process, and these groups are meeting all of the time. And we want to make sure that countries have a number of therapeutics that can be used to help patients, that they have access to these tools. It's not good enough that only some countries have access to these therapeutics. It's just not right, it's not fair, it's not ethical. And we need to make sure that these treatments are affordable. So we're working through many of our partners, and particularly through our ACT partners, to ensure access and to ensure adequate pricing, and to make sure that these treatments actually get to the people who need them most and are not hoarded by others.
Thank you so much, Maria. I know we are running out of time for today. So maybe before we close, we received quite a lot of questions from viewers today as well on what we are seeing, that many countries are lifting all the measures, and you already expressed your concerns, how that can impact testing and surveillance, and for us to track where the virus is and evolution of new variants. But given this current status of the pandemic where we are, where the virus is everywhere around us, is still heavily evolving, and we have lifting measures on the other side. So what is your outlook, and what can we expect from this virus? And maybe this is how we can close with all your points of view on the situation.
I mean, it's a really important question, Alex. And so we are asking all countries and individuals to be cautious. We are not out of the woods yet, and this pandemic is not over. We understand completely the desire to want this to be over. We want it to be over as well, but it's not. This virus is circulating at a very intense level. We've talked for an entire hour about the potential for further virus evolution and variants to emerge with characteristics that we cannot predict. So it is really important that the systems that have been put in place for COVID-19, and in many countries have been built over years, over decades, in fact, are strengthened. We want to see strong surveillance for COVID-19. That doesn't mean testing everyone everywhere. It means strategic testing and making sure we understand this virus, who is infected. We want to make sure that those systems are in place to sequence. So we have intelligent sequencing around the world to help us detect and track these variants. We want to make sure that there are strong health systems in place so people get the care that they need as quickly as possible, that they can get that. And that comes from surveillance and detection and supporting our health workers and supporting the patients to get the care that they need. We need to beef up our supplies for testing, for personal protective equipment. We still have healthcare workers around the world who don't have adequate protection. This pandemic is not over. We need policies in place to support people to protect themselves. We are now seeing a lot of the policies shift responsibility from government to people. We also understand that, but we also need people supported, communicated with, not to, engaged as part of the response, because pandemics begin and end with people. And that is really critical. And we need people to know what their risk is every day, because the situation in every country is so different. We are asking people to continue to follow simple measures, to wear a well-fitting mask over your nose and mouth, particularly when you're indoors and around other people. Make sure that your hands are clean when you do so. Make sure you watch your distance. Stay home if you're unwell, and make sure that governments and businesses support that in place. We are asking people to invest in ventilation. That's not only good for COVID, but it's good for other contaminants and other pathogens. Not once have I said lockdown. Not once have I said shut people away. What we need to do is find the right balance of reducing transmission while saving people's lives. The most critical thing we need right now is increasing vaccination, and increasing those in particular for those who are most at risk. People with underlying conditions of any age, people of older age group in all countries. And this remains fundamental to ending this emergency of this pandemic that we are in. So it's a long-winded answer because there's so much we can do. I'm cautiously hopeful for this year that we could actually end the emergency of this, but we cannot do it alone, and we can't do it with words. We cannot do it with words. We have to do it with actions. And we need countries to continue to be vigilant on this. It is not the time to abandon everything that has been built. It is certainly not time to abandon the science and public health practice that we know saves people's lives. So we will continue to share this information. We will continue to work with countries to ensure that we save as many lives as we can, because we can. And all lives matter. Not just lives in high-income countries. All lives in every country matters. So we will continue to do this, and we will continue to advocate for this at a global level, at regional level, at country level, through our staff and through the ministries of health and with politicians and with all of you. But please, if you're listening out there, continue to be vigilant, continue to take steps to lower your risk. Know what it is where you live. What is your risk where you live? And take steps to lower that risk.
So much, Maria. This was a great comment for the end from you, for people watching, but also for policymakers and decision makers. And I would like to give the floor to maybe Dr. Anurag, and then we will end with Lorenzo here in the room. Dr. Anurag, what is your last message for our viewers given the current situation?
My last message would be listen to Maria. No, on a serious note, that I think Maria articulated the points very well. Lower your risk using sensible measures wherever you are. Masks and vaccines are critical, simple things made widely available. And we'll continue to make the efforts to, provide you the latest information that we can. That's it from my side.
Thank you so much, and thank you so much for finding the time to be with us today after your dedicated time yesterday and almost every week to support WHO. We are very grateful for your role and advice, and all the experts that are part of the group as well. Thank you so much.
Thank you very much.
And Lorenzo, the last word is on you for today, on your message to our viewers, given the situation and all the science that you are seeing every day about this virus.
Yes, no, I think Maria covered it incredibly well, and Anurag as well. I think from, I'm focused on virus evolution, and from the virus evolution, as I mentioned already, we don't know what's going to happen next. We don't see a regular pattern as we see, for example, for influenza. And so really, again, listen to Maria, listen to Anurag, and yeah, that's all I have to say.
Thank you, Lorenzo, as well, for being with us today and for sharing your views as you're deeply in science that we are following in all our recommendations that Maria well articulated, but it all comes from the scientists in WHO and around the world who are providing us with the data and also advice. So my deep thanks to all of you for everything that you're doing. You're all, the three of you, real experts. Again, I will highlight that. And I also want to thank all our viewers from Kenya, Indonesia, India, Bangladesh, Singapore, US, Spain, Trinidad and Tobago, Poland, Ghana, Nigeria, Egypt, Iran, New Zealand, Lebanon, El Salvador, and many others as well. The list is long, so big thank you for staying with us, for following our advice, for following the science. And until next week, please stay safe.